We're at the 4th BHD Symposium at the campus of the University of Cincinnati. My name is Jill Woodward, and I'm speaking with Dr. Frank McCormack. Dr. McCormack, can you talk about the conditions LAM and TSC and how they relate to BHD?
Tuberous sclerosis is a tumor suppressor syndrome, meaning that it's a condition in which multiple tumors form throughout the body because of the loss of a protein that controls cell growth. When that protein is lost in the heart, heart tumors develop, in the lung tumors develop, in the kidney tumors develop, and in the skin tumors develop. So it's like Birt-Hogg-Dubé, it's a genetic condition in which protein is missing. And it so happens that the protein that's missing in tuberous sclerosis is in the same pathway as the protein that's missing in Birt-Hogg-Dubé. LAM is a condition that often accompanies tuberous sclerosis. It occurs in about 30 or 40% of women who have tuberous sclerosis and in about 10% of men who have tuberous sclerosis. And it is basically a metastatic neoplasm, meaning that a tumor forms somewhere, we're not sure where, and seeds the lung with smooth muscle cells that infiltrate and eventually destroy and form cysts throughout the lung tissue. LAM also occurs in a form that is not associated with inherited abnormalities in tuberous sclerosis genes. It's called sporadic LAM. It occurs after embryogenesis, meaning that you don't inherit it from your parents, that the gene defects occur at some time after conception. Sporadic LAM is less common than tuberous sclerosis-associated LAM, but we see it more frequently in our clinics, probably because it behaves more aggressively. When you do genetic analysis on peripheral blood in a patient with sporadic LAM, there are no abnormalities in tuberous sclerosis genes, but if you're able to obtain tissue from the actual LAM lesion or the kidney lesions that occur in those patients, they have tuberous sclerosis mutations. So it's a genetic condition, but not a transmissible condition. There are no mutations in the germline cells, like the egg or the sperm, and the condition cannot be passed on to offspring.
How often do you see patients, and how does that affect your approach to research?
So I see patients every week, mostly in a half-a-day-a-week clinic. It's a referral clinic for patients with cystic lung disease. So I see many patients with LAM and patients with other forms of cystic lung disease, and that raises a lot of questions for me. I have many of the scientific interests I have come from that clinic. I also have a research laboratory that's focused on pulmonary infections and pulmonary innate immunity, and I hope someday to be doing LAM research in my lab as well. And I can't overemphasize or overstate the importance of both doing clinical work and understanding how to make advances in the laboratory. The role of the physician scientist, I think, is threatened. The funding in the United States, at least, has taken quite a dip in the last several years, and I fear for the fate of physician scientists. And I think they're absolutely essential to making advances in medicine, and especially in rare diseases like Birt-Hogg-Dubé and LAM, where pharmaceutical companies are unlikely to become interested in doing trials.
Do you think doctors who see patients with spontaneous pneumothorax consider LAM or BHD as a diagnosis?
I think that's the exception. I think mostly because of efforts of the LAM Foundation over the last 15 years, I think most pulmonary doctors have heard of LAM. I don't think most pulmonary doctors have heard of BHD. When we introduce it to fellows while we're training them here, it's apparent that they've never heard of it in their residency training. And often when I encounter private practitioners in town, it's not a disease that they're familiar with.
And how feasible would it be to develop a drug for BHD?
So the first question with BHD is what the target would be. You know, the most threatening manifestation of BHD is the kidney tumor, and I imagine the first trials that'll be completed will be targeting that organ. The lung disease natural history is much more variable. Most patients don't have progressive shortness of breath. Many patients, about a third of patients, will have pneumothorax. But that's a sporadic event. It's not clear that taking a drug on a daily basis to prevent something that could happen sporadically makes a lot of sense. So we'd have to think clearly about what we're trying to accomplish with a pulmonary trial. I think the renal trials and perhaps dermatologic trials will precede pulmonary trials, and perhaps we'll learn something from those that'll help us in deciding what can be done for the lung.
And can you give us more detail about the sirolimus trial?
That was an investigator-initiated trial, meaning that we started it here at the University of Cincinnati. It was conducted at 13 sites in 3 countries. We enrolled 89 patients over a period of 2.5 years. The trial took about 6 years from start to finish, cost about $8.5 million. Patients were randomized to receive either sirolimus or placebo for a year and then to be watched for a year. We followed pulmonary function over the course of that time, and also measures of quality of life and pulmonary symptoms and CAT scans of the lung. And the most significant finding was that patients who took the placebo lost about 11% of their lung function in the 1 year on the trial, and patients who took the drug had stable lung function with no loss of lung function. The difference was highly significant. When we stopped the drug, both groups declined, so the sirolimus group began to decline again. So it appears that the drug suppresses the destructive process in the lung, but doesn't reverse it or put it in remission, just holds it in place. So it raises the question of whether the drug would be needed continuously, whether you'd have to take it for a lifetime, basically. And in some ways it makes some sense, because basically LAM and tuberous sclerosis are a deficiency of a protein called tuberin or hamartin, and sirolimus mimics the function of the missing protein. So like insulin for diabetes, you're simply replacing a function that's been lost through a genetic misadventure.
What results have you achieved so far, and what do those results mean for the future of LAM research?
As a field, there's been absolutely phenomenal progress on this pathway, understanding this pathway and identifying targets that are promising for future trials. LAM is one of the most devastating manifestations of tuberous sclerosis. It's one of the most lethal. And so it's a prime candidate for future trials, but there are also brain tumors and kidney tumors that are targeted in tuberous sclerosis trials. We have a lot of ideas for next drugs and combinations to try. There's several trials that have started up just in the last year around the world. LAM and tuberous sclerosis are an exemplar of what can be accomplished in a laboratory and brought to the bedside for the benefit of patients. I think BHD is going to be the same. It's just as decipherable as LAM and tuberous sclerosis are. We have scientists who know how to dissect the pathway very carefully and find the proteins that can be targeted for therapies. So I think there are going to be great advances in BHD, just as there have been in tuberous sclerosis and LAM.
What are the largest research needs in understanding pulmonary symptoms of BHD?
So I think very early, I think patients have to organize in a way that we can ask questions. So for LAM, for instance, Sue Burns at the LAM Foundation organized basically 1,000 or 1,500 patients over the course of the first 10 years of the foundation in a way where we could access their information, know who was available for trials, conduct surveys and questionnaires, and learn, for instance, about pneumothorax. In LAM, we did a study and determined that pneumothorax occurs in about 70% of patients with LAM. It recurs in about 70% of patients. Using that information, it's not too difficult to conclude that we ought to fix it the first time the pneumothorax happens, so that future events are prevented, because there's morbidity associated with future events. We also did surveys to determine if air travel was safe, and that's been very useful for lifestyle issues for LAM patients. We need to do that in BHD. It's very simple. You need a contact registry through the foundation or some other entity so that we can design a questionnaire and distribute it and find out how many people have had problems during air travel. That's low-hanging fruit, and that's perhaps not hard science. That's clinical science, but it's important for patients. And I think that's where we need to start for the lung. And we have to define the natural history of the disease to know what's targetable. We have to know how quickly cysts progress over time, if pulmonary function changes over time. Once we know what those changes are, we can determine if we can favorably affect loss of lung function by using various drugs. And it's very possible that many of the same ones that are useful in lamb will be useful in BHD.
You're the scientific director of the Lamb Foundation. Can you describe the foundation and what its aims are?
Yes, so the foundation was founded by Sue Burns and her husband in 1995 here in Cincinnati. I had just met her. I'd moved here from Denver, and when I arrived here, there was a letter on my desk. It's actually the office right up there, from her asking if I could do something to help her daughter, and frankly, there wasn't a lot I could do. There were no therapies then. We simply mostly observed patients with LAM, but she said, instead, if you can't help me with her medical issues, can we do something together to start a foundation? So she set about assembling all the patients she could find, and she's been accruing patients at the rate of about 100 a year for the last 15 years, and we're up to about 1,500 or so total. She also, with help from others on the board of the foundation, has developed effective ways to raise money, and so far has raised over $15 million, and about 10 million of that has gone into research. And I'm proud to say that that research formed the basis for many of the trials that are underway now.
What do you think the role is for the Lamb Foundation? And can you talk about any suggestions you might have for similar rare disease organizations?
We have a big interest in rare disease here in Cincinnati, and we're actually in the process of forming a center for rare lung disease. And there's nothing more important than the patient organization part of this. When things are as rare as LAM and BHD, unless the patients organize themselves, it's very difficult for the medical community to do it in a way that can promote trials and get research done. So it's essential that that BHD, like LAM, start to organize and to make their patient base available for research and for answering questions.
Dr. Frank McCormack, thank you very much for talking with us today.